Actually, it is my favorite to present the ACS, acute coronary syndrome, because I'm practicing in anesthesia of cardiac patient for non-cardiac surgery. That is why it is vital to know everything in details. What is the ACS? And facing such a problem in ER, in emergency room, as not coming in a typical presentation. Maybe they will come in a typical presentation. The objective of this lecture is clearly to understanding what is the clinical spectrum of the ACS, acute coronary syndrome, first, and to know exactly the presentation of the ACS. Then we can to judge what kind of drugs, what kind of medication that use it for such a problem. The pathophysiology of the ACS simply 95% from the ACS is due to rupture of atherosclerotic plaque rupture, or maybe due to spasm of the coronary artery. And once the spasm is established, there is a thrombus coming and enhancing inside the coronary artery and impair the coronary circulation. And we will see what will happen in the wall of the coronary artery and how the coronary artery will obstructed and narrowing and decrease the blood supply for the myocardium. This is exactly the pathophysiology of ACS. What is the ACS? Do you have any idea what is the ACS? Yes? Yes, 3 categories. Okay, can we consider stable angina one of the components of the ACS? Definitely no. ACS exactly, non-stable and unstable angina, non-STEMI and STEMI. And again, the pathophysiology of such disease, we have to know exactly what is the layer of the coronary artery, adventitia, media, and intima. The lipid particle, lipid molecule, it will sequestrate under the intimal layer that form the intraluminal and intra-intimal thrombus. And the presentation depends on the flowing of the blood through the coronary artery. So the presentation is established in an unstable angina. But the presentation is not like unstable angina. Why? Because the caliber of the coronary artery wider than the unstable angina. So here stable angina, but it is really asymptomatic because of the diameter of the coronary artery as well to nourish the myocardium. But when it increases the metabolic demand of the patient, like upstairs or doing exercise, that the demand become more than the supply, that give the presentation of retrosternal chest pain, exertional dyspnea, and so on. So, and this happened in stable angina. But in unstable angina here, which is totally different because the diameter of the coronary artery is different from that diameter. There is a narrowing and there is injury to the intimal layer with the processing of the accumulation of the platelet and making a thrombus with the build up the thrombus until reach to the critical point and give symptoms of non-STEMI than myocardial infarction. This is exactly what's happening in acute coronary syndrome. So as we said, the sequestration of the lipid molecule inside the intimal layer and that form intra-intimal and intra-luminal thrombus, and this is a figure, while this is a disfigured coronary wall. So unstable angina, non-STEMI, and STEMI, how can we classify it according to the clinical presentation, as we said in the objective of this lecture? What are the difference between stable angina than non-stable angina? Yes?
Stable angina only happens when there's exertion, but unstable angina can happen with minimal exertion or at rest.
Stable angina, retrosternal chest pain, provoked by exercise and relieving by rest and relieving by nitroglycerin, as simple as such. Unstable angina, unprovoked by exercise, maybe not relieved by nitroglycerin, but how can we differentiate between them? By ECG? ECG may be similar. Maybe even in unstable angina, that doesn't give it ST elevation, ST depression, T inversion. Sometime maybe give an ECG, normal ECG, and there is no elevation in the myocardial enzyme or cardiac markers, right? But why all of these happen blurred or confusing between stable and unstable angina? Simply because there is no cardiac injury. Once the cardiac injury happens, the troponin and cardiac marker release to the circulation. Then presented with the ST depression T inversion in non-STEMI and the cardiac marker with the increased level of troponin as a result of, as we said, myocardial necrosis mean myocardial death or cellular death. Okay, so this is a difference between unstable angina and non-STEMI regarding to the level of cardiac marker, regarding to the ST ECG. While in cardiac myocardial infarction is profound sign and symptoms. ST elevation, first, left bundle branch block, which is commonly not happen in unstable angina and non-STEMI. STEMI is already declared on a such way. But if we consider and if we see what is the more dangerous, non-STEMI or STEMI? What do you think?
STEM.
Non-STEMI, exactly. Non-STEMI is more dangerous than STEMI. STEMI, we all of them know that this STEMI is established and we can treat it by a certain medical treatment or other intervention. While non-STEMI, we are still worried when STEMI it will happen. So put the patient in very close monitoring, and we suspect or expect to do or to pass in STEMI at any time. So exactly, yes, you are right. STEMI is more non-STEMI is more dangerous and more critical than STEMI. Yes.
Please, how we can say that non-STEMI is more dangerous? Well, STEMI cause more death and cause more complication and cause more cardiac damage.
We know that the STEMI, ST elevation, and there's
Vascularization.
yes.
STEMI still more has much more mortality.
We couldn't do anything in non-STEMI, but we can do anything in STEMI. Get me? Good. So this is what we see in classical stable angina, and as exactly unstable angina. We see that we said that before, unprovoked or prolonged episode of prolonged chest pain, raise suspicion of acute myocardial infarction without definite ECG or laboratory evidence. Unstable angina. Non-STEMI, it is infarction. So what shall we do? What shall we expect in the investigation? Troponin is high, yes, because myocardial infarction, although it is not present as ST elevation, but there is a cardiac necrosis and cardiac cell damage. So troponin laboratory test showing release of troponin from the damaged heart and elevated cardiac marker. What are the cardiac markers? Yes?
Troponin.
Okay.
We have myoglobin.
Troponin, creatinine phosphokinase, lactate dehydrogenase, and aspartate. Aspartate aminotransferase. Aspartate aminotransferase is exactly raised after the troponin, but it will stay in the circulation for a short time. But in our practice, unfortunately, we don't aware about the IST because there is no specific sensitive test for IST. So while STEMI sustained chest pain suggestive of a myocardial infarction with the left bundle branch block. What I want to say to present all these is very common, but what are the problem in our casualty? So I will cross over the session to the very important slide. What are the acute coronary incidents in summarized way? ECG, anybody coming to the casualty and suffering from the retrosternal chest pain, and from the history, we have to do ECG simple. ST elevation, non-ST elevation. So if non-ST elevation, what shall we do? What shall we do? Send him for cardiac marker and other troponin. Cardiac marker, positive myocardial infarction. Myocardial infarction, either STEMI or non-STEMI. STEMI with the Q wave, non-STEMI without a Q wave. But the crossover can be non-STEMI developed to real myocardial infarction and presented in ECG as in a Q wave, and vice versa. While if a cardiac marker is negative and not presented in high sensitive troponin or CK creatine phosphokinase, so this is unstable angina. Treatment by MONA. And what is MONA? Morphine, oxygen, aspirin, and nitroglycerin. Save it as such, MONA. So why MONA? Aspirin is antiplatelet, and we will see in the diagram of the management, real management of the ACS, to enhancing how much is very important to enhancing the circulation through the coronary artery. Okay. This is our goal in ICU and ER. Patient coming to the ER has retrosternal chest pain, radiated to the lower mandible, to left shoulder, to elbow, and to little finger. You can't imagine, to little finger. Maybe come suffering from the chest pain, dalek in nature, and little finger. What kind of this complaining? Okay, this is a hysterical. Give him such Brufen or Voltaren with Buscopan, or maybe cimetidine IV, and that it is go back him to his home. After 2 or maybe 3 hours, will come as a dead or cadaver. And most of the society, unfortunately, they are very erupted, and there is no any excuse, because it is a fatal mistake to not keep it under monitoring. Even chest pain, not presented in ECG, but you have to keep him under your observation and under your vision. So activated EMS. What is EMS? Emergency Medical Society. And set ABC approach. ABC. Prepare CPR. يا ستار شنو عندنا صار؟ Prepare CPR, and we will see in the station with the Kakahama how he will suffer from retrosternal chest pain, and then he will die. But hopefully Moayad, he can to resuscitate him. Moayad and Ranj. Okay, so prepare CPR and defib. Why defib? Because higher percent of cardiac arrest contributed to pulseless VTVF. So when you come to the casualty and hand over or receive your duty, you have to check very important thing. And one of the important thing, DC shock. Maybe you will find DC shock is not charging. Very common in Iraq, very, very common. So how can you charge it? Or maybe DC shock is not available in casualty at all, because one of the responsible person leave the casualty and locked the DC in local. Okay, so as we said, if the patient come, set approach ABC, prepare CPR team, and defibrillation. Immediate emergency department. Oxygen is very important when the saturation less than 94. What is the normal saturation? Oxygen saturation?
94 plus.
94 plus. Okay. So give him the oxygen face mask, reassure him, and open the IV access, and set the MONA treatment. Now, ECG, we have three possibilities. Either a normal ECG, or ST depression T inversion, or ST elevation. Look, you are asking me why non-STEMI is okay. Non-STEMI is more dangerous than STEMI. We will see. At the ECG normal, as I said, you have to put your patient under very close monitoring, and you have to take a serial troponin, a serial cardiac markers. And maybe during such time, yes, when you take cardiac marker investigation at the time of arrival, maybe you will find that there is no wrong with him. Cardiac marker, troponin, all of them normal, but maybe in the subsequent hours, the cardiac muscle will be destroyed and release of troponin with the cardiac marker. So we don't lose anything, just 6 liters of or 10 liters of oxygen in the face mask. Okay, then take a serial cardiac marker and the troponin. So if it's okay, then discharge him with the follow-up. Discharge him with the follow-up. But if the troponin cardiac marker high risk, then shift to the category of if the patient coming with the ST depression T inversion. So, is there any criteria for doing an invasive strategies in such ST depression T inversion? What are the criteria? Of course, if the patient come with the ST depression T inversion, if he has a persistent, 5
minutes.
5 minutes, good. انت لو ما قايل لي انا ترى رايح بيها. If a persistent ST depression and variability. If the patient has a refractory chest pain not relieving by nitroglycerin. If the patient has a VT, ventricular tachycardia, vitally unstable and sign of heart failure, then there is an indication for invasive goal of such a problem. What kind of the management? We have to give him nitroglycerin, or first of all, antiplatelet, glycoprotein 2A, 2B3A, and what is this inhibitor? Of course, this acts as antithrombotic because it has a mechanism of action as antiplatelet and anticoagulation. That is why we have to take a precaution to not give it oral because the risk of perforated DU is very high. So clopidogrel, and by the way, glycoprotein 2B3A working as adenosine diphosphatase inhibitor, and as well as the mechanism that we already said it. So clopidogrel, glycoprotein, and the beta blocker, especially when the heart rate is above 100, because in tachycardia, increased myocardial oxygen consumption, over demand. So how can we limit the size of myocardial infarction? We have to reduce the rate. So beta blocker reduce not only the rate, reduce the mortality up to 40%. It's not joke. So monitoring, the bedside monitoring, and all of these lies على range. But if the patient coming with the ST elevation with left bundle branch block, then we have to take a history. How much time we need to decide whether shift for intervention or to shift for intravenous or intravenous medication. If the patient come with the chest pain less than 12 hours, thanks God. Why? Because we have a thrombolytic strategies, and we have PCI. So once when the patient came to the hospital, we have to prepare anything within 30 minutes if we plan to give him a thrombolytic. 30 minutes from door to IV to needle, just 30 minutes. While if we decide to decide to do PCI, no more than 90 minutes. So 1.5 hours. This is below 12 hours. But the problem when the patient come and he was suffering from severe chest pain since day before yesterday. So there is no any role for PCI or thrombolytic than shift and treated as ST depression T inversion. Thank you so much for us nice listening. Ranj, are you happy?
Happy with time.
Okay, thank you.
Okay, and the next speaker will be Dr. Ranj Khaffaf.